Thanks so much for joining our webinar titled Changing Landscape of U.S. Healthcare for Patients, Families, Clinicians, Researchers, and Health Organizations, a long list. And we have representatives from almost every one of those groups here today. The idea here is that basically the healthcare system in the United States is going through significant upheaval, some evolution, some devolution. And it's actually been a period of time where we really want to have a better understanding of where things are headed, what things are happening legislatively in policies that are shaping the experiences of patients and clinicians, as well as researchers. And also, where do organizations like the RLS Foundation, which is sponsoring this town hall, along with Project Sleep, who is also here with us today, and also Wake Up Narcolepsy. What is the opportunity for those groups as well to help support the mission of healthcare in the United States? So that's what our town hall is about today. But before we get started, I'll hand it off for some ground rules discussion with Adriana from the RLS Foundation.
Okay, yes. Thank you all for joining. Just to give us a couple of baseline rules for today, all participants will be muted during this time, and the chat is off as well, which means all questions and topics were submitted in advance. And so we collected all of those, combined the questions today, and we will have a roundtable discussion momentarily. And then just keep in mind that while all the panelists will examine policy and legislation, this is a nonpartisan discussion and use the opinions of our panelists today. If you do have any questions, either following up after our discussion, or if you have technological difficulties during this time, please email info@rls.org. Thank you.
All right, thank you, Adriana. So to start off, let me just first introduce myself, since I will be moderating, hosting you here today. My name is Jeff Dermer. I'm the chair of the RLS Foundation Board of Directors. I'm also a sleep physician, neurologist, neuroscientist by background, and I work mainly in the sleep technology development world, but also in actually bringing different levels of patient healthcare through tele-based means through a company that I work for called Absolute Rest. And today I'm also joined on our panel by Phil Goglas from the Health and Medicine Council of Washington, D.C. Phil's a managing partner of HMC, and it's an organization that guides and coordinates advocacy efforts for organizations, including the RLS Foundation and Project Sleep. So Phil's going to be the one who gives us a little bit more of a background discussion before we kick into our town hall discussion. Also joined with us today is Grant Thompson from the RLS Foundation. He's our legal consultant. As well as Carla Diezenkowski, who's the RLS Foundation Executive Director, as well as Julie Flager, who's the President and CEO of Project Sleep, Tammy Anderson, who is the Executive Director of Wake Up Narcolepsy. And then also we're joined by two physicians today, besides myself. Dr. Brian Koo, who's certified in both neurology and sleep medicine, and he is a medical director at the Sleep Lab of Veterans Affairs in Connecticut Health System and the director for the Yale Center Restless Leg Syndrome. Also, we have Dr. Mark Buckfuhrer, who's also board certified in sleep medicine, pulmonary diseases, and internal medicine. He teaches sleep medicine to doctors trained at Stanford Sleep Medicine Center and also in the RLS clinic there. So those are going to be our panelists for today. And just so you know, the next steps that we're going to go through is a discussion from Phil, a bit more about policy and issues that are currently hitting us all in terms of medical healthcare delivery, but also research and also the effect it's having on patients and patient care. And then after that discussion, we'll have a bit of a roundtable discussion on 4 different topics. The first being the impact of policy changes on the sleep community. The second being healthcare accessibility and its effect on clinicians and patient outcomes. The third area of discussion will be the current state of research and future impacts. And then finally, challenges and opportunities for collaboration for sleep health organizations. And I'm going to ask Adriana to keep me honest in terms of timeline, because this isn't going to have, this is going to end, not going to end on Saturday morning. We're going to have this thing end exactly 90 minutes from when it started. I think that's right. So she'll make sure that we time out properly. All right, you got the ground rules. You're on mute, but your questions have been brought in earlier, so we will ask a bunch of questions that people have asked according to the subject and topic that we're going to have a discussion around. So, with that, let me first invite Phil to give us his discussion for the next 10 minutes on current policies and some of the interesting changes that we've all been aware of. Phil.
Thank you, Dr. Dermer. It's always dangerous to let a DC-based person start off, but I'm going to try and stick to less than 10 minutes because, one, I don't want to get too much in the weeds and bore people, but I think it's going to be really important to have the actual discussion with all of our panelists here. So, as Dr. Dermer mentioned, I'm Phil Goglis. I work here in Washington, D.C. on behalf of the Restless Leg Syndrome Foundation. We also work with Project Sleep and a number of other sleep organizations as well. So my job here in Washington is to be, eyes and ears for the sleep community and sharing key information that comes from the federal government, whether it be Congress, the House and the Senate, or the administration. And it's no secret that there has been no shortage of activity going on since the beginning of this year. So I always like to level set with folks when starting these types of conversations about where we are, quick refreshers on how DC operates, because I think that's critically important as well, because there are a lot of things, especially in today's day and age, that, folks will hear, read, or see. And I think it's important to just start with that base level of how things run here in Washington, because then I think it helps put into perspective different pieces of information that we receive. So we are in the start of a brand new Congress that was sworn in earlier this year in January. And as a result of the elections last November, Republicans maintained the majority in the House of Representatives. They won a majority in the Senate and won the presidential election. So there is a Republican administration. So anytime that there is a one party that's in control of both the House, the Senate, and the White House, they call that the trifecta here in Washington. And you would think that that means it's going to be easy. It's one party controlling the entirety of government. They'll be able to, get through their priorities and a rapid pace of legislation will ensue. That's rarely the case when you do have the trifecta of one political party overseeing the House, the Senate, and the administration. There's just a lot of things that they have to deal with and focus on. One thing that happens on an annual basis is appropriations, and that's funding the government. So that process traditionally starts, and for those of you who have participated in advocacy before, have received action alerts, have gotten outreach about how to engage with your House member, how to engage with your senators. That process starts right in January when they get sworn in, whether it's for the Department of Defense's peer-reviewed medical research program, whether it's for key recommendations at the National Institute of Health or the Centers for Disease Control and Prevention. There is a lot of activity that happens at the beginning of the year. When a new Congress is sworn in, it takes a little bit longer just to get everything off the ground and running. Now, in a perfect world, the Congress this year would have been sworn in January. They would have started on appropriations with a new administration. The first 100 days are jam-packed with cabinet confirmations, other nominations, with key pieces of legislation, messaging bills that were talked about during a campaign to get the administration and the new Congress off and running. The issue is at the end of last year, Congress did not fully appropriate funds for the new fiscal year. So we were operating under a continuing resolution for quite some time. They just finished off that process in March of this year. So the first 3 months of this new Congress was focused on how to fund the government past March. Would it be a full year continuing resolution? Would they be able to actually fund the government for fiscal year 2025? And the reality is politics does play a role into how these decisions are made. So fortunately, there was not a government shutdown. They were able to come together and to pass funding for the government. The bad news is the way that they did it had some negative effects on the priorities that we all care about. So when you look at the Department of Defense, for instance, the peer review medical research program, sleep disorder and restriction has been listed as a condition eligible for study, and that pot of money has been at $370 million. What the Congress did in March of this year was to cut that funding from 370 million to 150 million. So sleep disorder and restriction has been included in that list of eligible conditions for study, which is great, but now there's significantly less money that is available to our researchers to compete for. In addition, I'm sure it's no secret to anybody who has joined our town hall here, there has been a lot of change at the Department of Health and Human Services and across just the federal healthcare agencies as well. With the new Secretary of Health and Human Services, Robert F. Kennedy Jr., there's been a reshuffling where through executive orders from the administration, through actions from the Office of the Secretary, there's been a significant shift in how NIH operates, how CDC operates, and how other public health agencies operate as well. So one of the most important things that our communities always support and advocate for is robust funding for the National Institutes of Health, specifically for a number of institutes that focus on sleep-related research and other key priorities for the sleep community. Now, we have heard in the past of recommendations to consolidate some NIH institutes, to fundamentally change how NIH is organized. That has not garnered a lot of support on the Senate side, but we have already begun to see where the administration has started to make some proposed cuts and eliminations, whether they be, and I know we're going to talk about this during our town hall discussion, whether it be termination of grants, specific changes that affect directly the ability for researchers to research and to provide that support, all of these critical things that are important to our communities. In addition to the NIH, you also have to look at the Centers for Disease Control and Prevention, which we work very closely with as well in terms of education awareness activities, but public health initiatives as well. There's been a significant shift at CDC as well, and across HHS where there's been a reduction in force. So a lot of folks have been laid off from their positions. That doesn't necessarily mean that the work is no longer happening. It just means that instead of 8 folks that are working on a project, maybe it's now down to 5 or 4 folks who are handling that project. Just today, we received some information on the skinny budget request, and that's the administration every year they have to submit to Congress how they believe the government should be funded. What should HHS be funded at? What programs should be included? And it is not surprising to any of us who work through this on a daily basis that the skinny budget that was released today significantly cuts funding for non-defense programs. The NIH, for example, the administration proposes eliminating $17 billion from their funding lines, proposes consolidating institutes, proposes eliminating some institutes, changes how HRSA, which is the Health Research Services Administration, works on workforce development programs to train the next generation of medical professionals, eliminates and consolidates some of those. A lot of critical programs at CDC proposes to eliminate and consolidate those. Now, what's important here is the administration does not have the power to fund the government. They do not have the power of the purse. That is the House of Representatives and the Senate. That's why we focus tremendously on engaging with the House and Senate, because they're the ones who make those decisions. So if you get a letter, and I'm sure folks have gotten the action alert or will be getting it to sign on to the sleep letter, engaging with your House member, that's why we focus on those activities. If you've gotten an action alert or encouraged to connect on Department of Defense with your senator, that's why we focus on that, because the House and Senate both have to come up with their bills, move it through their committees, pass it on the House floor and the Senate floor, and then get it to the White House for the president's signature. So there's a somewhat saying here in Washington that the president proposes and Congress disposes. So we look at what the president released today, all of his proposals to make those cuts. I can promise you now, and this is something I rarely do with Washington stuff, but I can promise you now, what Congress ends up passing will not be the same thing that the president proposed today. There are not a lot of supporters in the Senate, especially for eliminating NIH institutes, for eliminating programs at the Centers for Disease Control and Prevention. There have been numerous folks on the Senate side. Susan Collins, who is the chairwoman of the Appropriations Committee on the Senate side, has already come out against the proposed changes for NIH and how some mechanisms on research dollars have been proposed to be affected. The other issue is going to be math. And this is what I've been saying for, a few years now, and I'll say it for the next 2 years at least as well. In the House of Representatives, there is a slim and very slim Republican majority. It's slimmer than the number of panelists we have here on the call today. So I guarantee you, if you ask all of us here a question, maybe you'd get agreement, maybe you get some differences of opinion. And that's just with all of us on some of the things we're talking about here. Now imagine getting 435 members of Congress, 220 Republicans on the exact same page about everything that they want to do. That's incredibly difficult. And we're seeing how this is shaking out with current conversations on reconciliation. I'm sure folks have heard about proposed cuts to different health agencies or to different programs like Medicaid. And there's been a lot of conversations among Republicans about how do we get the votes to do this. Now, the reason why they're working on reconciliation this way is because they don't need 60 votes in the Senate to pass anything. They just need a simple majority. Now, when you're talking about appropriations, you need 60 votes in the Senate to pass, and that's to get through the filibuster and some other procedural hurdles. So in my estimation, it's going to be very difficult to envision a path forward where Republican senators support cutting NIH, support restructuring CDC the way it's proposed, support any of these things that we've seen out there. And I highly doubt that any Democrat senator is going to vote to support any of these things. Now, what does that mean for us? And I don't want to get too much into some of the questions that are coming up, but it means that our voice is even more critical at this moment. And it's really important for folks to continue to engage, to share your experiences, to reach out to your elected officials. And I'll talk a little bit about this in some of the questions, but we've already seen how effective that is within the last week here in Washington. So I don't want to spoil too much, but Dr. Dermer, I hope I didn't go over my time. I wasn't timing myself, but
No. You did great.
I feel like I'm starting to get on that roll, so I just want to back it up a little bit so that way we can get into the conversation.
You have incredible self-knowledge, Phil, and we're very, very blessed to have you on our panel today. So thank you so much for that very good introduction to what is happening right now here up to Friday, May 2nd at, well, let's say 2 o'clock in the afternoon in the mountain time where I am. But thank you so much for that, Phil. Now, we're going to move into the next part of our conversation here, which is more of the roundtable discussion, where each of our panelists are invited to provide their own interpretations, their thoughts. We like to hear back and forth. But before we do that, I only gave a brief introduction to each of our panelists before I handed the mic over to Phil. And I was hoping maybe we can get a little bit more information from each of our panelists as I call them out, so that you can introduce yourself to the organizations that are out there listening, to the people that are listening, to the patients. And I'm sure there are thousands of people out there listening on today's webcast. So let's start off. Carla Diezenkowski from the RLS Foundation, the Executive Director. Could you just give us a little background in terms of your own particular place here?
Well, thank you. And I want to thank everyone for joining us today and for our panelists for agreeing to participate. This is the first time we've done this and we've had an overwhelming positive reaction. But again, I'm Carla Diezenkowski. I'm the Executive Director of the Restless Legs Syndrome Foundation. The RLS Foundation is a 501c3 nonprofit dedicated to improving the lives of the men, women, and children who live with this often devastating disease. The organization's goals are to increase awareness, improve treatments, and to advance research leading to a cure. Over 12 million individuals in the U.S. have RLS. RLS is not chronic pain, treatments are not lifelong, and there is no cure. That is why awareness, education, and advocacy are cornerstones of our outreach activities. The Foundation sponsors the only dedicated research grant programs whose focus is identification of better treatments and a cure. To date, the Foundation has funded 54 seed money grants totaling over $2 million in funding, and that is from member designated donations. So thank you to our members for supporting research. Since 2017, the RLS Foundation's public policy initiative has focused on three primary areas: increased funding for medical research at the National Institutes of Health, NIH, and Department of Defense, DoD; awareness and education about RLS by funding the Chronic Disease Education and Awareness Program at the CDC; and protecting access to critical treatments that includes opioids. Specifically, we seek inclusion of RLS in any policy or legislation to maintain treatment access for low total daily dose opioid therapy. RLS is a common disorder affecting up to 10% of the population. 1 in 3 individuals requires daily treatment for symptom management. Maintaining access to opioid therapy for refractory RLS patients who have exhausted all other treatments is critical. Used in low total daily doses, opioids allow individuals to be contributing members of society. The opioid registry at MassGen has found that tolerance and dependence are not issues common to the RLS cohort, and that low doses used for RLS remain stable for decades. The RLS Foundation hosts a Hill Day each year to encourage members of our community to share their RLS experience with our policymakers, to provide firsthand experience of living with RLS and its impact on quality of life. RLS advocacy serves 5 critical purposes: to educate and raise awareness of RLS, eradicate stigmas associated with the disease, seek research funding and support at the NIH and DoD, insurance coverage for all treatment modalities without step therapy requirements, and fifth, this is the most important, knowing that your outreach played a critical role in adopting these measures, leading to improved quality of life for RLS patients and all others in the sleep community. So thank you for joining us today, and I look forward to a lively discussion.
All right, thank you, Carla. Next, I'd like to ask Julie Flagger from the Project Sleep to give us a little more background as well.
Thank you. Thank you for having me today. So excited to be with you guys. You guys got a great turnout here. Very impressed. So thanks everyone for tuning in. I'm Julie Flaggar, and I'm in Los Angeles, and I was diagnosed with narcolepsy when I was in law school. So I'd originally gone to law school to study art law, but once I was diagnosed, I became very fascinated as I started to learn more about the Orphan Drug Act and trying to understand incentives for developing treatments for rare diseases, and ended up really focusing the rest of my law school career on health policy, which really just a very small part of health policy, and learned kind of like how you learn that there's so much more. Like I have one little area that I know a lot about, but I'm really grateful to work with HMC. Phil and Dane are incredible to help us as an organization know everything we need to know about policy and keep us informed, because it is so complex and there's so much going on. So Project Sleep is a nonprofit. It's kind of like an umbrella organization to raise awareness and advocate for sleep health, sleep equity, and sleep disorders. So we're looking to bridge conversations, especially between topics about sleep health and sleep disorders. We often see a big divide that people either want to talk about one or the other, and we think that both are really important, and equity as well, and that those conversations shouldn't be separate, but together. So some of our policy efforts are bringing the sleep community together through the appropriations letter that Phil mentioned, which hopefully will start on Monday, that will have a really big action alert coming out for people to reach out to their representatives. I think that this will be our 7th year leading the appropriations letter effort for the sleep community to promote sleep research and also sleep awareness through Health and Human Services and CDC to increase funding for sleep awareness efforts. So, and we also bring together the sleep community through something called the Sleep Advocacy Forum every fall, which is a really wonderful event in DC where we all, professional societies and patient groups get together and then go to Capitol Hill together to raise our voices. So a little bit about Project Sleep. Thanks again for having me.
Right, thank you, Julie. Next, I'd invite Tammy Anderson from Wake Up Narcolepsy. Tell us a little bit more about yourself and also about Wake Up Narcolepsy.
Thank you for having me today. As mentioned, my name is Tammy Anderson. I'm the Executive Director for Wake Up Narcolepsy. We are a nonprofit organization dedicated to driving narcolepsy awareness, education, and research. Our mission is deeply personal to me, as I'm a parent of an 18-year-old who has been living with narcolepsy for the past 10 years. I see daily the challenges that our community faces, the struggles to find answers, access to care, and understanding when living with a sleep disorder. Funding research to help accelerate the path to better treatments and ultimately a cure has always been an important part of our mission, and we've awarded $1.6 million to date. Increasing awareness of narcolepsy and other sleep disorders is a central focus of the work that we do. We aim to shorten the time between symptom onset and proper diagnosis, which can still take many years for families and individuals. And we provide supportive resources, not just to individuals living with narcolepsy, but also to their families and caregivers. Through the educational webinars, local events, peer-led support groups, and participating in events like today, we bring people together across roles and experiences. So whether you're a person living with a sleep disorder, a clinician, a researcher, or an advocate, there's a place for you in this community. And we're grateful for all of the work that is being done in this space, and that we're able to collaborate with other organizations and individuals working to move this forward, because it's not something that can be done alone or by one group. So I'm looking forward to the discussion ahead and the ways that we can work together moving forward in our shared goals. Thank you for having me.
Thank you, Tammy. It's great to have you. Next, I invite Grant Thompson. Grant, please give us a little more information about your background and your role today.
Sure. I'm Grant Thompson. I'm in Washington, D.C., although I am firmly a Westerner, born and raised in California. And I'm by training a lawyer, although I have not practiced law for a very long time. I've been involved in nonprofits for most of my professional life, both as a researcher and as a board member and executive director. And my work at the foundation is somewhat Mr. Inside. I try and be a resource to our excellent board of directors and to our executive director. I have decades of experience of working with volunteers and working with volunteer boards. And I have not only the scars and maybe some of the wisdom that comes from achieving those scars. So, and I got into this because my cousin has RLS, and he was involved with the foundation, and he said at a time it was going through some difficulties, they could use some advice, and I've been delighted to do that ever since.
Great. Thank you, Grant. Next up, Dr. Brian Koo. Can you give us a little more about your background and your role today?
Sure. Thanks, Greg, and thanks very much, everyone, for inviting me. Very happy to be here. I'm Dr. Brian Koo, an associate professor of neurology at Yale University. At Yale University, I direct the Yale Center for Restless Legs, which is a Restless Legs Foundation Quality Care Center. And I'm very lucky to take care of a lot of restless legs patients from a number of states in the Northeast. And it's through these activities and this care, working with the patients, that I have really learned a lot about the disease, how to treat it, and also have gotten clues as to what different biology may be involved. And so in addition, at the Yale Center for Restless Legs, where our mission is to provide excellent care for patients with restless legs, we also are very interested in studying restless legs. And I'm very fortunate to be working on a study then I'm looking at the mechanisms of restless legs, and this is funded by a Restless Legs Foundation grant. So this work is very important to me. I've been working on it for many, many years now, and it's one of the hats that I wear. The other is our third main mission at the Yale Center for Restless Legs is to train the next generation of clinicians on how to take care of patients with restless legs. A lot of you may know that there are not that many clinicians out there that know how to treat very severe restless legs, especially once it has been augmented. So I'm happy to say that every year I train 4 different sleep fellows in exactly how to do this. And some of them stay and some of them disperse. So they're going out there to help everyone. Yeah, so I also was very lucky a few years ago to be awarded a Department of Defense grant to study also the mechanisms of restless legs. And that grant, although modest from a federal standpoint, was really a game changer for me, and it really allowed me to get into this question. And some of you may know the research, but really happy to talk about this very important topic, and really optimistic that we could brainstorm some solutions to the challenges that we will face.
All right, thank you, Dr. Koo. And finally, Dr. Mark Buckfuhrer. Great to see you, Mark.
Hi, nice to be here, and again, thanks for inviting me. So I am probably one of the older people in this group, at least, and in the restless leg, doctor group. I'm initially a pulmonary or lung specialist who, after getting my pulmonary training, got board certified in sleep medicine also. And I got involved in treating restless leg patients in 1992, just as the Restless Leg Foundation was coming into being. And partly through that, a patient who got me involved was getting information from the Restless Leg Foundation as they were using their high-tech equipment called faxes in those days to pass information along. Anyway, since then, I've gotten developed one of the biggest restless leg practices in my office, because especially back here, I'm in Downey, a little town in the Los Angeles area. There just aren't a lot of other restless leg specialists here. So I've gotten one of the biggest practices. In addition, I'm also an associate professor at Stanford University, where I run the restless leg clinic there. I go up once a month. So I also see patients there from all over. Over the years, I've actually been involved in the research projects to get some of the drugs that are approved for restless legs, to get FDA approved, etc. And 2 devices, one the vibration device, which isn't being made anymore because although they did get FDA approval, they couldn't get Medicare coverage. And the latest device, the neurostimulation device called Tomac, or its brand name is Nidra, which got FDA approval after a little while of doing some research, and as of October got coverage from Medicare. So we're seeing some traction with that, and if maybe I can certainly answer questions about how that's working, since I probably have the most amount of patients on it and still doing research on it than anyone anywhere.
Absolutely. Well, thank you so much, Dr. Buckfuhrer, for being here and for all of your work in the past as well. And we will get into some discussions, certainly about the current state of research and future impacts. That's something that we're going to be talking about in our third topic today. But I want to move us to our first topic. Now that everybody's had a chance to know who's here and why we're here, the first topic today is, what's the impact of what Phil was talking about, policy changes on the sleep community? And really, I want to just kind of throw out the first question here to Carla, because she, as an executive director like Tammy and Julie, both have to deal with policy and even work with Phil, which is nice to do. It's not you don't have to deal with Phil, you have to work with Phil. It's nice. And the question I have is, broadly, how do you feel that legislation or policy is impacting organizations like the RLS Foundation, Project Sleep and Wake Up Narcolepsy, and other nonprofits? And I'll certainly open up, since I did use two other organizational names there, open that to Tammy and Julie as well. But start off, Carla, with your thoughts on how that's impacting organizations right now.
Well, as a funder of research, we are in the middle of our research grant program, and in January, when these policy changes hit, and they hit hard, our researchers were calling us, "I need funding. I'm nervous. This is scary," and so it just made this research grant program that we have all the more important to keep labs open, because it's not just the lab. It's about the training the next generation. It's about continuing research. People are concerned, it's voicing concerns about, I'm in the middle of a study. I need to keep it going. What's going to happen in April? So know that, that was one of the big things that hit hard to our community, because that's a ray of hope for all of us in the sleep community. We're always looking for the next treatment that's better, that's going to change that cure. We always want a cure, because who wants to, we always think about your next generation, your child, your grandchildren, etc. Even now, what's going on today, that I would be able to go to the pharmacy and pick up my medications. People have expressed concerns about the impending tariffs on medications and how the costs are going to affect their ability to afford their medications. So, or even accessibility to them, will they be able to get them? So that has been two things that have been raised up to me. And Julie and Tammy, I invite you to chime in as well.
Yeah, Julie or Tammy, please jump in. But also, I just wanted to introduce another face to the crowd here. Josh Fain just jumped in from HMC. This is one of Phil's colleagues from HMC. Welcome to the group, Josh.
Thanks, Dr. Dermer, and sorry, I had to jump off before to take care of something, but yeah, I wanted to make an appearance.
Yep, we appreciate you being here. All right, so I'll pass it over to Julie or Tammy. Please, love to hear your thoughts in terms of the impact, and maybe more even about the impact that it's had on your actual organization, and what you've had to actually do since these changes have occurred.
Thank you. I'll jump next. I just was going to mention, I think, we talk often, there's a lot of rhetoric and then there's sort of like reality. And, sometimes the rhetoric, we can say, oh, that's just talk and that's not action. And I know that's an important differentiator, but I will say for the work that Project Sleep is really focused on, which has to do a lot around reducing stigma, raising awareness, trying to get people to realize like, someone living with a sleep disorder isn't like from a movie that they're just going to fall asleep while they're standing, or having a CPAP isn't like a death sentence or something. Like, we're trying to reduce stigma around these things. So I think the rhetoric is actually really important and really, really challenging and disappointing when you hear things around questioning the Department of Education and the role of IEPs and 504 plans. Like, that rhetoric matters in how we talk about other people that are living with really serious conditions that a lot of sleep disorders really are included in. And we've been, as invisible, often very invisible sleep conditions, we've been fighting to be recognized like as disabilities that can receive 504 plans, that kind of stuff. So that's really scary. I will say for us as an organization specifically, we haven't had any major impacts yet from, very, the policy changes so far. It's just extremely scary, the cultural changes. Even like sleep equity is a really important element of Project Sleep's work and our strategic plan for the next 5 years that we just developed in December. Over all of last year, but we come up with this new strategic plan, and equity is one of the 4 main things. And all at once now, you talk about equity, you're like being shushed, and that's just a really scary change in our culture. So that's what I'll add.
Yeah, no, so the point being that really the uncertainty itself has actually led to a lot of rhetoric, as well as also uncertainty in terms of your own planning, perhaps, which is really impactful in many, many ways. And Tammy, what would you say to that as well for Wake Up Narcolepsy?
Yeah, so Julie brings up some really important points that I think are essential for Wake Up Narcolepsy as well in the work that we do. And I want to echo what Carla said. We have seen a significant increase in the need for research funding. So many more researchers are reaching out and asking what's going to be available, what the process is going to be for this year. And so we have a lot of work to do to secure additional funding to be able to continue those projects. It's going to be really important for community support in that area. And, to Julie's point that we aren't really sure, it hasn't made a huge, we haven't seen big impacts yet, but there will certainly be some things coming. So we're just going to stay vigilant and monitor the situation and try to adapt as needed to support the community and help improve access and support to meet new requirements.
Just a quick follow-up for you, Tammy. One of the things that I think we've all seen is significant changes at the FDA and its oversight. Do you feel that, from your perspective, that changes at the FDA could accelerate or delay approval processes for new drugs and therapies, even specific to narcolepsy, but even more so sort of looking at medications for other sleep disorders and not getting approval from the FDA just because of the current processing?
Absolutely. I would like to think that, we could remove some of those barriers and that it would be, an easier process, but I think that's definitely one of those unknowns that we can hope for and advocate for. There's already so many barriers to access that it's just something that we were really going to have to stay vigilant on and work as a community, all of us together here today and other organizations, to make sure we don't have additional barriers put in place.
And I invite any of our panelists to also chime in on this question, because I know it's something that policy from Phil and Josh's perspective, the physician's perspective, Mark and Brian, but also Carla, I saw you raising your hand there. What would you like to add to the discussion?
Well, the new D1 receptor drug that we're looking at for a clinical trial, I think it's a phase 2 for RLS. We're sort of in a holding pattern right now, and I'm basically pumping the two researchers that are working on this, and they're like, I just don't have anything to tell you. I'm like, when can you have something that I can tell our community so that people who have augmentation know that there might be another therapy out there that is available to them at some point in the future, we hope. So that's what, some of these policies are doing. We're getting slow walked on something that is so critical when we have very few drugs. We don't have a lifelong therapy for RLS, and we need something that's more durable.
Anyone else? Brian, Mark?
Well, I think I'm next to talk about something that dovetails onto this,
Yes.
Which is about insurance coverage for medications and FDA approvals, which is kind of what we're going into. Let me just say that even before this new administration, I had to basically hire an extra person just to do prior authorizations. Being a specialist, both pulmonary and sleep, I use so many drugs that are, newer, more expensive, not as well covered, obviously. And again, I have to hire an extra person just to do the prior auths. And often, many of my drugs I use, the first prior auth doesn't work. Eventually, I have to do even a peer-to-peer, meaning I have to talk to someone at the drug company that is usually a doctor, but they may not be a specialist in that field. And I'm having to explain to them why I need the drug. And sometimes they even agree it sounds like a good idea, and the drugs still don't get approved.
Yeah.
Very worried, especially in the last couple of days when, which will affect some of my pulmonary patients. You may have heard that as far as vaccines go now, if they make an alteration to like one of the existing vaccines, like for COVID, that it'll be considered a new vaccine, and they have to do placebo trials. So by the time the new the new COVID vaccine directed at whatever's around currently or recently, will get approved, it'll be history. So there'll be something new around, and it won't even be useful. So I'm very, very worried about what's going to happen for the drugs I need for both pulmonary and sleep. And,
Yeah.
and I can say that prior to this, the FDA approval for both drugs and devices that I've been involved in have been pretty reasonable. You do the studies, and you get at least FDA approval. As far as Medicare and insurance coverage, that's a different story. But I think that's going to be slowed down. And as far as medication coverage, that's going to get worse and worse and tougher.
Yeah, and you bring up a very good and actually adjacent topic, which is even if it's FDA approved, it's not necessarily going to be something that a patient has access to through their health insurance, which is, I think, at least as a physician myself, I don't know about Brian, I'm sure has a similar experience. There are many drugs that we try to utilize in patients that are already FDA approved that have indication, but just simply aren't covered. I mean, a simple example of that is GLP-1 inhibitors for people with obstructive sleep apnea and obesity. We know that that's an indication, it's been approved, but we don't have coverage for that. So a lot of people don't benefit from the drugs that we have available, even at the moment. All right. Any other comments before we move on to our second topic? Carla.
Well, another comment is that some of these insurances require step therapy. So I've heard from many people, and I'm speaking from the RLS foundation perspective, who have been augmented, have been off a dopamine agonist for some period of time. Insurance changes, and they're like, oh no, we're not going to cover your alpha-2 delta ligand. You have to go back to dopamine agonist. And I'm like, this is crazy. So thank goodness for guidelines. We can send papers out, but it's a lot of education that goes on to assume that those are first-line therapies and they're no longer a first-line therapy. It puts a patient in a dangerous situation, where they won't have access to a medication that is now working for them, and forcing them to say, hey, you have to go back to this med that you really can't take. So those are some of the things that we need to consider, to address those challenges in the community and look to ways to improve that.
If I could just jump in.
Phil is going to ask you for your opinion on this too.
Yeah.
To that point, Carla, Congress has been aware of this issue when it comes to fail first therapy, step therapy. It has been a piece of legislation, the Safe Step Act, that has been introduced for many years. And I think it's just that is an example of how unfortunate Congress isn't working at the moment. Because if you go back, 2 Congresses ago, there was a majority of House members who were co-sponsors, a good amount of senators who were co-sponsors, and it couldn't make its way out of a legislative hearing. In the last Congress, the Safe Step Act was part of a larger legislative package that was moved through a committee hearing, was favorably reported, and Josh will correct me if I'm wrong, but had well over 218 co-sponsors on the House side, had, I want to say, close to 60 co-sponsors on the Senate side. So you're looking at tremendous numbers in terms of support across the ideological spectrum, the just sheer number of folks in the House, senators as well. It made it through a legislative hearing, was reported out favorably, all the things a piece of legislation needs in order to have final passage. But it was never teed up because of the political circumstances surrounding the end of the last Congress. So we know that it is going to be reintroduced at some point in this Congress. So do want to flag that for folks that, you will get an update on that in terms of asking your elected officials to support that. But that's just another example of how good policy has been introduced. We've worked its way through the legislative process, but sometimes there's unfortunate things that are outside of our control to actually be able to see that cross the finish line. But the positive is we have seen incremental progress in that bill moving forward. In the last Congress, it's moved further than it ever has before. So we're hopeful that in this Congress, we'll actually see some action on that.
All right. Thank you, Phil. And as we just wound up our first topic for the day, you led us very nicely into the next topic, which is really about accessibility, healthcare accessibility, its impact on clinicians and patients, and also patient outcomes. And my first question is for Dr. Koo. The question is, what changes to the Affordable Care Act, a different act than Phil was speaking about just earlier, might impact patient access to healthcare coverage?
Yeah,
From your perspective.
sure. It's a really important question because, you know, the Affordable Care Act, also colloquially known as Obamacare, really opened the door to Medicaid for millions and millions of Americans. And, you know, any cut to access to the Affordable Care Act would mean that many millions of Americans would not have health care. So Medicaid, you know, is government health care. And you know, back as a resident, you know that your resident clinic is going to be Medicaid patients because the private insured patients see the attendings and the residents see the Medicaid patients. And somewhat has been stigmatized. But I think that in more recent years, to some extent, it has lost that stigma because so many more people have Medicaid. In Connecticut, it's called Husky. So, you know, at the Yale, in my Yale clinic, the Restless Leg Center, I also see a number of other sleep disorders, sleep apnea, narcolepsy, and such. I see a lot of patients with state and federal healthcare, Medicaid or Husky, whatever you want to call it. And the coverage is good. You know, actually, in some ways, you know, in sleep medicine, our main diagnostic test is a sleep study. And Medicaid and Medicare favor patients have an in-lab study, whereas many of the private insurances will deny an in-lab study and say you have to have a home study. Whereas Medicaid and Medicare don't do that. And we like that because we'd rather patients have an in-lab study. It's a little bit similar with medication because, you know, just because you have good private insurance doesn't mean you're going to get good coverage for your medications because there's so many different rules. There's cost structure, there's formularies, there's deductibles. And as Dr. Bickfer was alluding to, it's the bane of a physician's existence to have to get on the phone and do a peer-to-peer review with someone who's trying to tell you that you can't use a medication, even though you know it's the medication that's going to help the patient. So very frustrating. And I feel that I have to do that more with the patients with private insurance than the ones with Medicare and Medicaid. So, you know, so really a cut to, you know, we're talking about the Affordable Care Act that affects more patients having access to Medicaid would really be, you know, would not be good for many Americans.
Yeah, I totally understand what you're saying. And actually, you just brought up Dr. Buckfuhr, so I have a question for him now because he's had to deal with Medicare, I'm sure, quite a bit as well. And the question I have for you, Mark, is the proposed changes to Medicare and Medicare reimbursement or coverage models. Do you think that they're going to be placing a lot more strain on clinicians and healthcare systems moving forward?
I have to admit, so far I've been listening as well as I can to, you know, because it impacts a huge percentage of my patients for both pulmonary and sleep. My patients tend to be on the older side. What I'm, again, so far, I haven't heard too many proposed changes to Medicare. From the sounds of it, they might want to attack Medicaid, here it's Medi-Cal in California first, but I'm hoping that they're afraid of the senior population of voters and they won't do much to change Medicare because the Medicare population is a very loud and vocal bunch of people. So I haven't heard anything yet specifically for the plans, but I think we have some experts who may know more than I know of what may be coming down. But just what I've heard for general consumption, I have yet to hear much impacting the Medicare reimbursements. And, you know, Medicare reimbursements have not exactly gone up a lot over a bunch of years. So I suspect it, now whether they'll go down much, I don't know. But if anyone else has more information, I'd be happy to hear it.
But, you know, one of the areas too, Mark, that might be of interest for people to hear a little bit about is telehealth capabilities as well. And, you know, telehealth really took off over COVID and has been allowed by Medicare and Medicaid, actually, for normal routine care. And sleep healthcare has really kind of risen within the telehealth space. If you or Brian, or even I'll love to get Phil and Josh's point in terms of the policies here next. But really, kind of, is that something that you see as being limited at all at this point in terms of the differences between Medicare and private insurers? And is there anything in the current telehealth environment for sleep that you're seeing as possibly positive or negative?
Well, I can answer that because a big part of my sleep practice, which is different than pulmonary, because pulmonary, I want to listen to the patient's chest and they pretty well have to come in unless it's something very simple. But a big part of my restless leg practice, because I see people from all over, but they do have to be somewhere in California because that's where I'm licensed. But I would say probably the majority of my restless leg practice and even narcoleptic patients, and possibly even sleep apnea patients, I can do by telehealth. And we were quite worried. I think it was March 31st was the last deadline. And my patients were really worried that they might stop coverage for the telehealth. And let me just say, we would probably still be allowed to do telehealth, but it wouldn't be covered by Medicare, and the other insurances would probably quickly follow because they all cover it now. Have to pay, they can still see me, but they would have to pay cash for the visit because it's not a Medicare covered service. So we can still do it. But anyway, we were quite worried because just up till a few days before, we were not sure whether they were going to extend it. And it got extended for another 6 months till, I guess, September 30th or something, October 30th, just because they put it in that bill, which was approved at the last minute. So if they had not approved that bill, we would not be able to do telehealth right now, which I'm still doing.
Great, great. And Phil and Josh, any additional information in the policy realm related to either the telehealth capabilities or even the model changes to reimbursement associated with Medicare?
Yeah. So to build off the last point, that was included in the full year CR to keep those telehealth benefits through the end of the current fiscal year through September 30th. So that was something that was a lot of negotiating back and forth. That was something that folks raised as an issue, and that was hard to get it negotiated in the final package. So there continues to be a big focus on these telehealth capabilities. The other thing that we've noticed here is the pandemic, even though we're 5 years post the beginning of it and a few years out from it officially ending, depending on how you want to view it, pulled back the curtain on what many of us have known for years, that there are large gaps in access to care for folks, that there are not enough primary care physicians, there are not enough specialists, there aren't enough medical professionals, and folks have struggles to be able to access those types of visits and that type of care. And if you look at where most of these folks have the trouble, it's in rural areas. So it doesn't matter if you're in a state like New York, they have rural areas. If you're in California, they have rural areas. Every state has them. So if you look at where the conversation has shifted to, rural healthcare is critical now. And one of the, what I call sexy new things to talk about on Capitol Hill that everybody cares about, and telehealth has become very popular among members of the majority in the House and Senate because they know their constituents depend on it. Because if you live in a very large rural area and are represented by somebody like Jason Smith, who's the chairman of the Ways and Means Committee, his district is huge. Not a lot of big cities in his district, not a lot of suburban areas in his district. So you're looking at folks who are his constituents that probably have to drive an hour or two maybe to see a qualified health professional. Good luck finding actual specialists in those communities. So telehealth has become very popular, and then those benefits, the ability to do that has become popular. The issue is if you live, in Manhattan, can you see Dr. Koo, who's in Connecticut? Well, if he's in Connecticut on camera and I'm in New York on camera, is that okay? So that's where some of the trickiness gets involved that we've heard from some folks. But when it comes to Medicare and Medicaid, you know, when I opened before talking about reconciliation, Medicaid has been in the news a lot, and how they're going to reform Medicaid. And they've talked about Medicaid, Medicare, and Social Security as entitlement reform as an umbrella term. They've really shied away from Social Security and Medicare. You know, to your point, Doctor, about those populations and their voting capabilities. But I think that's going to be very hard when you look at Medicaid. And there are a number of Republicans, again, more than the number of panelists on this screen here, who have said, don't touch Medicaid. Don't make dramatic cuts to Medicaid because it affects our constituents. And if you look at where a lot of these areas that rely on Medicaid or benefit from the use of Medicaid, they have been very vocal in telling their members, and I know this may bleed into another question that has come up, that's going to come up, but the reason why we've seen a shift in markups on the committee level on the House side is because of this outreach from folks to say, keep your hands off Medicaid. So you have folks who are engaged, who are saying Medicaid is critically important. It's a lifeline for our constituents. Anything that we're looking to do cannot make dramatic cuts to Medicaid. So that's one of the what I would call third rails right now for Republicans in terms of this reconciliation package of, are they going to cut Medicaid? How deep are they going to cut Medicaid? I think those of us who live and breathe this policy world know you can't come up with the number that the Committee of Jurisdiction was told to come up with without making deep cuts. So I don't know. Stranger things have happened, and I was mentioning to somebody who was on the Hill with me this week. You know, there was and I forget who the exact person who made this quote was, but talking about voodoo economics. I think you're looking at voodoo math here, when you see how they're going to come up with a specific amount without making dramatic cuts that we know that's the only way they're going to do it. So it's going to be interesting to see how all of this comes together. But I think the most important thing is for members to hear from their constituents, whether they're medical professionals, to hear, here's what's happening in my practice, here's what my patients are dealing with. Yeah. Or if you're a patient, here are the obstacles you have. Or if you're a parent, caregiver, loved one, what the experience is.
Yeah. So I think what we've really learned during the pandemic is that telemedicine works really well. And it works really well probably across just about all specialties, but particularly in sleep medicine, it works very well. And, you know, we have really drastically cut down the amount of telemedicine we do. And, you know, before we were able to see patients across state lines, and now that is not permitted at all. I have patients in New York, New Jersey, Pennsylvania, Ohio, even West Virginia, New Jersey. So they have to come at least once a year to Connecticut, which is obviously not easy for them. And even for those patients that are in Connecticut, you know, like Dr. Bucher was saying, it's often not, you know, the reimbursement is significantly lower. So there's a lot of institutional pressure for patients to come in, to really have patients come in. And, you know, I think we've forgotten how effective it is. And, you know, in that there are people that have a difficult time, you know, driving whatever it is, 60 miles or even more to see their doctor. And I think we also have to remember that for restless legs, particularly those who have augmentation, there are really not a lot of doctors in the country that can treat patients with augmentation.
Yep.
And so these patients, you know, some of them that are in states like Idaho, I wouldn't know where to send someone that lives in Idaho. Maybe to Mark.
Yeah, exactly. Yeah.
I actually have a whole bunch of patients from Idaho, and I see people from all over. But it's one thing I remember, just as Dr. Koo was saying, that during the pandemic, most states just gave us a complimentary license. You just had to send a little bit of information and you can see patients all over. Now, even if I see someone in Las Vegas, I have to have them drive 2 hours to State Line
Right.
in California. And I don't, you know, it would be nice if they changed the definition of, am I rendering care where I am or where the patient is?
Yeah. Yes. And this actually, I mean, just to put a ribbon on this one, because we have to move forward in our conversation to the next topic. I think there's a lot to say from what Phil was mentioning about grassroots efforts to get people's attention in Congress, just like we did with Medicare and Medicaid. Like people did, don't touch it. If we can get folks who understand the value of telemedicine for sleep healthcare to speak out more about this, maybe we can get to a point where where psychologists are with SIPAC relationships, where a single psychologist with one state license can then serve 30 or 40 different states under a SIPAC relationship. So I'll stop there because I know we have limited time, but it's a very, very important topic for accessibility on both ends, people needing the help and then having enough physicians and providers. All right, let's move to our third topic. It is about the current state of research and future impacts. Now, it's a big shift in thought process, but it's not that far from what we were just talking about in many ways. And my first question actually is back to you, Dr. Koo. What challenges do researchers currently face in securing research funding, and how might future policies create additional barriers?
Right. Well, that's pretty straightforward to answer in some ways because it is extremely difficult to get a grant. I've been spending my whole career trying to get a federal grant, and it is not easy. This is the hardest. You're competing against some of the smartest people in the world. You're also competing against people whose jobs are on the line. If they don't get grants, they have to leave their academic position. And so any amount of cuts to to an institution or to a federal institution for grants is going to make it harder. So I will just say I'm very lucky to have a Restless Legs Foundation grant, and I'm very grateful to all the members for helping to fund that. The foundation grants are less competitive, a little bit easier to get, but they're modest. So, for example, $50,000 is the size of a Restless Legs Foundation grant. And it's very important. It helps to cover the work, but it cannot sustain a lab, because to have a lab, you have to have a coordinator. You have to pay $80,000 per year. You have to have a research assistant, 2 of them, that make $44,000 a year. In addition to those salaries, you have to pay 30% fringe rate. So an $80K salary is going to be more along the lines of $120,000. So you could see that a foundation grant of 50 to 100K, while it may pay for the work, is not going to keep your lab open. And so then you have to apply for a federal grant in which the dollar amounts can be significantly larger. So the DoD grant that I was lucky to get was about $250,000 for 2 years. And that's actually, believe it or not, a small grant. But the funding lines for grants, NIH or so, are usually around 8 to 12%. So if you decrease the size of the pot, that's just going to be a lot harder. DoD is probably a little bit higher, but as you heard from Phil earlier, the pot of money went down from 370 million to 150 million. So they're just going to have the number of grants that they could give out is significantly less. And that's really one of the most kind of discouraging and unwelcome things. At the same time, I think you heard from Julie that some researchers unfortunately have to shift in what they research. So diversity and equity is a big area of research these days, and I feel very it's very challenging for patients, or not for patients, for persons that are currently researching that. And some people have built their careers on studying health inequity or health disparity, and it's going to be very hard for them to find funding. That's obviously very unfortunate. And I feel even if you're not in the area of health disparity, you have to think about, is this going to be something that's going to raise the eyes of someone who has a pen that says, no, this grant can't be funded because it's in this area. It certainly brings up worry in something that is already extremely difficult and challenging, and that you'd rather not have to deal with. But I think that gives an opportunity. A lot of us, I work with the development office at Yale to try to raise funds from grateful patients, donors. I think that this is so critical now, given that the uncertainty of where's the money going to come from, and that the Restless Legs Foundation, Project Sleep, as well as Wake Up Narcolepsy, has thousands of members, and you all have been very generous, and we count on your generosity to kind of help sustain our labs, keep the lights on and everything, keep the work going. So,
Yeah, well, Brian, one of the things also I wanted to ask you in more detail about was the effect of the policy changes directly with universities that we have all seen, from Yale to Harvard, to all of our national institutions that we have entrusted to actually do the research rather than just it being a centralized function of the government, which many years ago was the decision made after World War II. And part of that was the operation of actually found the monies that support the indirect costs, meaning the actual facilities that are necessary to do that. And the proposal to cap indirect costs at 15%, and the impact that that has. And I think also the misinformation that I've heard, and I'm sure many have, that indirect costs in a sense cut out how much money a researcher gets. And in fact, it's not that at all. It's actually a $100,000 grant. And if you had a 50% indirect, it's $150,000 now that is going to be provided, 50,000 to the school, 100 to the researchers. So a lot of the rhetoric around indirects has created a lot of confusion. But then also stories of 3/4 of surveyed researchers currently in healthcare research and other areas of science are saying they're looking and entertaining jobs outside of the United States. Have you seen this in your work, and has it impacted your facilities and your other colleagues?
Right. Now it is quite scary because, for federal grants, NIH and DoD, the indirect is 67% at Yale. So for every $100,000, Yale is going to receive $67,000. Now one could say, oh, what a sweet deal. Yale's really swimming in it from that. But these monies go toward, keeping the lights on, paying the electricity, paying the heating bills. Also that goes to covering salaries of either research nursing, or we have a lot of individuals that help us submit the grants, because you can imagine that a grant has 50 different pieces that has to be collated into a cohesive packet to be submitted, and there are people that help us with that. There are people that make sure that the budget that you propose is within the guidelines of the grant. So yeah, not having not having the 67% indirect and having it go down to 15% would really limit the ability of institutions to do that type of thing. I mean, unfortunately, I don't have a federal grant, so I haven't personally felt the pain, but and in the world I live in clinical research, also if you're doing basic science research, a lot of these monies go to the animal facilities and the massive amounts of manpower you need to who's going to make sure that animals are fed and the litter is cleaned and everything like that. These are jobs that you don't want to make a person, a researcher, pay for with their grant. These are where a lot of the indirect costs go. So yes, it's a very uncertain time, and it leads to a lot of uncertainty.
Yeah, well, I mean, personally, I can actually say as a member of the NIH Sleep Disorders Research Advisory Board, a part of National Heart, Lung, Blood, we have seen a significant downturn in actually meetings and just being able to communicate with our colleagues within the NIH. And the uncertainty, as we talked in the very beginning, has led to really a fear that this isn't going to continue as it has. And many of the people that I know who are the most well-trained and highly respected individuals in our country in research who have been leading institutes at the NIH are even kind of looking around to make sure that they have somewhere to land. You know, when 281,000 researchers at last count within the federal government are told that we're going to be reducing force by 20 or 50%, it doesn't leave one with a sense of security, which a lot of the folks working within this framework banked on. That was the reasoning for taking a job within the federal government at a much lower rate than you would have otherwise been able to procure out in the private sector or even within the university systems. So I think the uncertainty, the fear of federal funding itself being dramatically cut, but then also just the cut of number of people. I know that we're going to actually be getting together at the NIH Sleep Disorder Research Advisory Board later in the year, in August, finally in person, but our April meeting was cut off. We've not had any other discussions since then, and no conversation. So the fear is real. The jobs are real. The impact across the academic centers is real. And research itself is in a very precarious position right now. So another area to step up and talk to people in your government to get them to support NIH funding, as well as institutional funding for federal government grants that really create innovation. And I think everybody's heard the dollars spent within the research community in our medical research in particular, NIH dollars, begets over $2.50 of revenue back to us as taxpayers. Comes back to us in innovation, new products, iPhones, and all the rest. So very significant area of interest. All right, we've not beaten the dead horse, but we've heard this one before. So let's move on to the next topic. The next topic is going to be about and our last topic, challenges and opportunities for collaboration for sleep health organizations. And luckily we have 3 health organizations represented here in terms of .orgs, but also we have Phil from and Josh here from a governmental perspective in terms of what kinds of opportunities could be leveraged in the political end to improve our situation currently. So let me start with Phil and Josh, actually. What are the most effective ways that patients and clinicians can advocate and continue to help improve access to affordable evidence-based care?
So I'm probably going to steal some of Julie, Tammy, and Carlos' thunder here, but biggest thing is
don't worry.
is get involved, reach out, and say that you want to participate in advocacy. I know that it can seem daunting. You know, we're talking about Medicaid, Medicare policy, access issues, you know, funding, and somebody may say, well, I'm not an expert on any of that. I'm not really sure the inner workings. You know, I look at the news and I see dysfunction. Is my voice going to make a difference? How do I even start? Easiest way to start is just reach out to one of the organizations and say you want to participate. There are a lot of materials that we work on putting together to just make things as easy as possible for folks. The most important thing, and what I always stress to people, is the only thing you have to be an expert in is what your experience has been. You know, what sleep condition do you have? What sleep condition does a loved one have? What is your experience with it from your perspective? We help you prepare your story. You know, we give you the tools and the resources to connect with your elected officials. We're the ones who get into the weeds on the policy and talk about all the technical issues. But the most important thing you can do is to share your story. I know that everybody knows this, but you know, there are 435 House members, 100 senators, 535 members of Congress. Josh and I are very good at our jobs, so we are friends with most of those offices, and can go in and say, "Hi, Bill, I need you to do something for me." And Bill would say, "Okay, Phil, okay, Josh, great. I'll sign on to that letter or I'll do this." The one thing Bill will ask us is, "Can you have a constituent reach out to me so that way I can flag it from my boss? Is there somebody in our district or somebody in the state that we can talk to that can share what their experience has been, so that way we could just note it that we've had constituent outreach on it?" So that's the most important thing, is having that ability to say, "Yeah, I'm going to connect you with Carla from Texas, or I'm going to connect you with Dr. Dermer from Colorado, or Dr. Koo from Connecticut." Being able to do that really does make the difference. But I'll turn it back to you because we'd love to hear more
Yeah.
from Carla, Tammy, and Julie.
Yeah, absolutely. Actually, I was going to ask Grant's opinion here because we haven't heard from Grant yet. Because I know he's worked very intricately with the RLS Foundation for a number of years, and has his legal background and very big brain. Very helpful to hear your thoughts on this, Grant, especially with opportunities as you've been involved with the RLS Foundation.
Sure. I think I can remember once that I was complaining about something to a friend of mine, and he said, "It's time for you to stand up on your hind legs and start talking." And I really do think that the advice that Josh and Phil have said about getting constituents involved. I know the foundation does the Hill Day, and they bring people in, and that makes an enormous difference when they, the mother's milk of a politician is a voter, and they don't like to piss them off, and they like to at least give them some hope. So I think that's one area that it's really important. And if you can't get to Washington, you've got a phone, you can write a letter. So I think that everybody who has access to people who are directly affected by disease or by need for funding needs to be very active in reaching out to their members and to the families of members, to be active citizens. This is I think we're seeing a period in which the nation generally, on a whole range of issues, is finding people finding their voices and getting up on their hind legs and talking. And we need to be part of that conversation.
Yeah, that's great, Grant. Thank you. That's really the message, I think, of today as well. Tammy, more specifically, if you could quickly, with the limited time we have, are there any messages in particular that you would suggest people focus on that'll garner bipartisan support, since that's one of the main things we need to do here?
Yeah, I appreciate what was already said because our communities are great at sharing stories. And so giving them that permission to share their stories is really helpful. Sleep is truly universal to the human experience. It affects everyone. So we all know what it's like to be exhausted or struggle through a day with a poor night's sleep, right? That shared understanding gives sleep health a unique ability to unite people across the political spectrum. Narcolepsy, for example, doesn't discriminate based on background, profession, or political affiliation. And in moments of change or political excitement, it's natural to feel like we need to do something big or take a new approach. But the truth is, some of our most meaningful progress has come from sticking to the fundamentals, raising awareness about sleep health and sleep disorders, pushing for better access to care, supporting research, and educating both the public and providers. These basics matter, and they're still the core of what we need to do. So our message doesn't change. It's already there. We just need to keep doing the work, keep showing up together, and staying steady on our mission together.
Yeah, oh, that's great. Thank you, Tammy. And Carla, could you briefly give us some of what your organizational accomplishments have been based on previous advocacy efforts?
We lobbied for CDC inclusion, to remember to think about RLS not to put us in an exclusionary category for opioid access. I know I've talked about this, but this is a hot button issue for our community, keeping that going. Also, I'm going to talk about some other hot button issues. One is really hot right now, is that we just found out from HBTRC, which is the Harvard Brain and Tissue Resource Center, that they have been affected by the changes with the NIH cuts. So we don't know what's going to happen with tissue donation and also banking those gifts so that our researchers have access to that. But I would also ask everyone to follow us on our social media sites, because we're in contact with Phil and Dane all the time at HMC. As soon as it's out of their mouth, it's on our social media. I want you to follow us. I want you to become back active and engaged in the community, in the sleep community. And I think that is the most important thing is to do, is your voice is your advocacy. And I invite all of you to follow us on our social media. Here are our handles, and get involved. That's the first step.
All right, thank you, Carla. And Julie, a bit more from you as well about current efforts with your organization, and also how people can stay involved.
Yeah, thank you. So just building on what everyone else has said, Project Sleep leads the appropriations letter effort that we've been talking about a lot today, and we will have an action alert that should come out on Monday, and that is a key time of year. So this is just luckily timed advertising for our initiative that will launch Monday. It'll be a very short turnaround. We'll probably have a week or two and it's very easy. We give you a template letter that you can copy and paste and send an email to your representative's health assistant, and we help through HMC. We help you get it to the right person in the congressional office. You're not just filling out like an online form. It's really a specific email sent to the right person in your congressperson's office to sign on to that letter. So we hope we get a good number of co-signers. I think our biggest letter, we've had up to 36 or 38 signers on that letter. So I hope we can get a good letter this year and bipartisan support. The letter is focused on supporting sleep research at NIH and also having a coordinated effort for the CDC and HHS to address sleep education. You know, I think it's really exciting that that the administration maybe takes a fresh approach in looking at chronic health and chronic illness, and that's wonderful. That's invited. But what's not invited to me is to say that chronic illness is important, but we're not going to fund the research. And so, you know, if the administration takes seriously what they want to talk about, then they need to put the funds behind it. So hopefully our efforts can help with some of that. And yeah, truly everyone's voice matters. I know some people on the webinar have been dedicated advocates. I want shout out to Matt Horsnell, who tries every year to get his representative to sign on to the letter. And even though I don't think has been successful yet, you know, he keeps trying every year. And that education is really, really important. So thank you guys.
Thank you so much, Julie. And thank you all again for being here today for our town hall. I just want to close by really kind of connecting a couple of one thing. This is a very concerned time. We're all very uncertain about the future. And you may have seen other webinars and discussions, especially in the sleep space. I know Dr. Dan Busey, who is the president of the Sleep Research Society, actually had a town hall not too long ago. And I really loved what Dan said. As a psychiatrist, he says things that are very wise. And what he left us with was how to actually work through this uncertain time using psychological practice. And that is work with what is important to you. Focus on one thing. Focus on something that is impactful to you, and don't worry about everything else, because everything else is happening around the thing you care about. And if you do focus on that and you write letters and you stay the course, that will make the most of an impact that you possibly can. And your psychological well-being will be preserved. So think about it from the perspective of what you can do, influence, have as much input as you can. And by that, hopefully you will also feel a little bit better about where you are currently in this bit of a sea that we're all adrift about in at the moment. So With that, I ask you all at the end of this to fill out our post-webinar survey. And post the survey will post all socials for post survey to include all socials for participating organizations. Oh, I'm not sure what socials mean, but maybe that's social media. Is that what it is?
Yes.
Adrian? Okay. I just showed my generational age there by not knowing what socials were. Yes, so it'll all be shared in the future. We really thank everybody for their time here. We thank Carla from the RLS Foundation, Julie from the Project Sleep. We thank Mark and Brian, our physicians, Tammy from Wake Up Narcolepsy. We really thank Grant for coming on with his expertise and background, as well as Phil and Josh, our representatives out there working their hardest for us on Capitol Hill. And with that, thank you so much for joining us today. Hope you enjoyed this. Hope it was stimulating. I hope we didn't stir up too much, as well as gave you a little sense of things you can do about this situation these days, not just feeling like you're being put into a position where you can't do anything, because you can. You're an advocate for yourself. All right. Thank you all for joining us today. Have a great weekend.
Thank you, everyone.
Thank you.